It's a pleasure and privilege to be here. I was telling Dr. Agrawal what a fantastic conference this is. I really enjoyed it last year. So this is really the starter for the session this evening. So it's nothing academically stimulating or challenging. It's rather simple and straightforward. So that's me, consultant clinical microbiologist at Blackpool Teaching Hospitals, and it's just a case study. Right, so I have to ensure that I meet with the requirements Dr. Agrawal placed, that there should be some question and answer slides. So the first one is going to be, please vote your favorite choice, or at least a tolerable view. Would you go with Star Wars, Harry Potter's, Lord of the Rings, or Mr. Bean? Very, very interesting indeed. Okay, moving on. So I've just got a single case, and I'll spend a few slides to just talk around, brushing up the background about malignant pleural mesothelioma. Then I'll come to the challenge, and I'll really need your input to help us tackle this challenge. Yes, and I must acknowledge that we had to really put our thinking caps on, and without a doubt, Professor Kibler and Liz Johnson were extremely helpful in this case, as ever. So, pleural mesothelioma, it's a rare neoplasm with a relatively poor prognosis that develops from the protective lining that covers the organ. And that's a cartoon which is showing that how you have this extremely growing edges from the pleura inwards. And patients do end up with getting an empyema, and it's rather late in the disease that they start to have any symptoms, and by the time they present, there's little that can be done for them, hence the poor prognosis. That's a CT scan of the chest in patients with malignant pleural mesothelioma, and you can see from those red bars at how this sort of encloses on the lung. Now, depending on the extent of the disease and at the point at which it's been picked up, if the patient indeed is a candidate for surgical intervention, then you can have a wide variety of surgical interventions that might be carried on. It might be as little as a partial pleurectomy or decortication, or indeed you may need to take the entire lung out. Patient might undergo a pneumonectomy. Now, in this particular case that we'll be talking about, the patient had to undergo a radical extrapleural pneumonectomy, which meant removal of the lung, parietal and visceral pleura, pericardium, and majority of the hemidiaphragm. So anything in contact with the malignancy has to be removed. And then, since the intestinal loops or the heart could herniate into the empty cavity, a prosthetic mesh had to be placed to keep them in their place. So essentially, as I mentioned, that the symptoms only when the disease is rather advanced. Median survival rate is anything between 6 to 18 months, again depending on when the patient presents. The evidence suggests that multimodality therapy is associated with a longer survival. However, it just depends at what point that the patients would present and would they be a candidate for that multimodality therapy. The surgery, when it can be undertaken, which is for about 20% of patients, it's usually a cycle of induction chemo followed by a surgery which may be pleurectomy, decortication, or EPP, and then it's followed by the chemoradiotherapy. And as you can imagine, there can be lots of complications as a patient goes through this. So ours was a 63-year-old patient who was a ship dock worker, and he might have had asbestos exposure, but we weren't sure and couldn't really tease that out. So he was identified as a case with the malignant pleural mesothelioma, and he underwent induction chemo, and then the radical surgery at one of the surgical trial centers in the country. And then 2 weeks after finishing his chemoradiotherapy, he came back and he started to have some chest symptoms, with which he came to the cardiac surgeon clinic. He was given some antimicrobials and then sent home. He presented again after a couple of weeks. This time he was more unwell. And the CT scan, initial X-ray followed by a CT scan and then a bronchoscopy revealed that he had developed a bronchopleural fistula in the right pleural cavity, which simply meant that post-pneumonectomy, where they had completely stitched the bronchus, it had broken through. So there was a direct communication. And one of the complaints was that he was really coughing out feculent smelling sputum. And there was a buildup of level of collection in the empty cavity. An intercostal chest drain was inserted that drained a thick yellow fluid. And not surprisingly, the surgeon didn't send it for culture. Does that often happen in your setting? No, never. Patient wasn't doing very well. He was losing weight and seemed septic. There were some renal and liver impairment. He was anemic, hemoglobin of 7.8. White cell count wasn't tremendously raised, 12.1. CRP more than 180, creatinine clearance of 40, and raised ASDL, alkaline phosphatase. He was treated with a range of empiric broad spectrum antibiotics, and then the surgeons, because he had a collection that was rebuilding, they decided that one could keep the chest drain in, so they created under GA a 4th and 5th resection and created a window on the side of his chest just to allow free drainage of the empyema cavity. Through the entire perioperative period, he received a variety of antimicrobials including Kefenmet, cefuroxime and metronidazole, then tazocin changed then to meropenem and teicoplanin. Thankfully, not everything at the same time. However, things weren't settling down. He was having an unresolving pyrexia. There was a copious wound discharge. And once we were involved with the case, we had insisted that let some regular sampling be sent to the lab so that we pick up something earlier rather than later. So a variety of blood cultures, urine, sputum, anything that moves, included some swabs for sent for culture. And actually we didn't get anything except for something from the swabs. And what was more interesting was, I've got here, that was the window, and that's a video clip of what was lying inside. It'll help you appreciate. That's your aspergillus growing inside that empty cavity. So it was loaded. And what was really worrisome was that the prosthetic mesh, which was lining the pericardium and the hemidiaphragm, well, everything was loaded. So consistently pure profuse growth of Aspergillus fumigatus from every wound swab sample obtained at dressing changes. The examination revealed this was initial, that's the prosthetic thing over the diaphragm. That's a zoomed view which had gray cottony growth lining the mesh and the rest of the chest cavity. So here we come back to your interaction. So in someone with that, what would you choose to use? Would you use a systemic azole, Vori, Posa, or isobuconazole, a systemic amphotericin preparation, systemic echinocandin, or an alternative management? And just to assure you that Dr. Johnson told us that it was perfectly sensitive to all of them. So what would you consider using? Please vote. That's very interesting. So would somebody from the alternative management just speak up and tell us what would you do?
He needs to derive.
Sorry?
Just antifungals.
Yeah.
Antifungals are necessary. I think he needs surgical debridement.
Anything else?
Also do washings of the cavity.
Absolutely.
Like
Topical and taking my shower.
Right. Now, that was one of the challenges. How do you wash something like that? I think we had debridement, we had washings, etc. What else can be done? Okay, so alternative managements, we looked at all that, should we do a combination of debridement and a GA plus systemic antifungals, or just try a combination of systemic antifungals and some local antifungals, or a combination of debridement, systemic and local. None of the above, something else. So please vote. Okay, so most of the audience have gone with option 3. How about the 5%? What else would you like to do? Would anybody like to speak up?
I mean, you could add something to option 3, but you wouldn't do none of the above.
Okay, agree. Okay, so moving on, what exactly did we do? The patient was initially started on voriconazole and then changed to caspofungin because the LFTs were getting worse. However, the systemic antifungals failed to clear the fungus, and essentially his further surgical management was really put on hold because till the fungus could be cleared, there was nothing that the surgeons wanted to do with this patient. So what did we do? Now, if you just appreciate, this will help you through the challenges that I'll pose subsequently, that here you have a cavity, and if you decided to do some washes, how would you afford the extended exposure to the antifungal? Now, the problem was that the systemic antifungals with that prosthetic mesh around was with very limited vascularity, wasn't clearing anything for us. So with those in mind, I think our key challenges were that this was an unusual topography and the extent of aspergillus fields. The prosthetic material was extensive, there was limited vascularity, and yes, we would like to consider a combination of all those 3. But when it comes to local topical antifungals, how would we do something to allow for an extended exposure? Which agent should we use? Should we go with amphotericin or voriconazole? Should we use powder? Or try and mix the antifungal with some sort of a gel base or a liquid? What sort of a delivery method would allow us an extended exposure? How much to use? How long to use? Any thoughts? Yes. We did. So Rashmi's suggestion is ask Professor Kibler. So that's what we did. In fact, we tried to look up the literature, speak to most of the key opinion leaders, and we were still trying to contemplate that actual solution of the extended exposure wasn't a simple one. And we sat with our pharmacy dispensing unit lead, with the medical director, because this was a salvage situation and we had to put our thinking hats and do something different, which may not be aligned to any evidence base. So innovative deliberations, and obviously we obtained patient consent. Now, we weren't sure, and I'm still not sure, whether our approach was the Bush approach or the Trumpian approach about global warming, but it was somewhere in between. And essentially, we decided that we would take all the 3 things together, and with regards to local exposure to antifungals, one of our cardiac registrar, he made an interesting point that we could use some sort of a Haemostat agent because they have tissue adhesive properties. So if we could get the antifungal to the walls, then we could use a Haemostat. And we looked into our cardiac theater for what they were using at that point in time. So we used I think oxidized regenerated cellulose or one of the microporous polysaccharide spheres. And you have a wide variety of these available in the market and especially in the theaters. So we use one of those. And just to share with you that since that first patient, we have had a second one. And I would really consider asking you your thoughts that if we had a third one, how could we do it better? So we use the fibula, and essentially how this was done was there was a video camera that was put through that hole. The surgeon in the first instance, he used curved spoons to really debride the most that they could out of that cavity. And then after they had done that, we went on to use something which they use in the cardiac theater. There is a place for putting the tube with the inflation bulb that you use in a sphygmomanometer. This stuff opens up and you can put whatever you want to spray, and then you've got that mouth which can be used. So through the cavity, this was put so that they could spray something at a 360 degree. So now the question was how much and what. So between amphotericin B and voriconazole, amphotericin B was off patent, cheaper to use, little problems with going off the license, so it was easier. And how much was a difficult one as well. So we just brought 10 vials of amphotericin B. I accompanied the surgeon and we said we'll try and do something and decide on the spot. So he sprayed till everything was yellow. And then fibrillar sheets were used to do the packing up. So under GA, debridement was done, spray with amphotericin B, hemostat pack. The procedure was repeated after a week, and we looked at the renal functions to ensure that there wasn't any further renal impairment from something getting into the system, amphotericin B. There wasn't any change, which sort of reassured us that we could have used more. Oral posaconazole was given for 6 weeks. Satisfactory levels were ensured, and then we extended it for 6 months. Following negative cultures, the patient went on to have a planned surgery and closure of his bronchopleural fistula. And then towards the end of the year, all his prosthetic mesh was removed. And he made a good recovery from this complication. Unfortunately, I've learned that both those patients, they passed away from their baseline malignancy. But at least we could solve this one out. Thank you very much.